Hello, everyone. My name is Andrea Begotka. I'm a pediatric psychologist at Children's Wisconsin and Medical College of Wisconsin. And I'm here today to talk to you about the multidisciplinary treatment for children with choking phobia. So we're going to start off by identifying the signs and symptoms of choking phobia and hopefully helping you to understand the multidisciplinary approach to treating choking phobia. So I'm going to go through and define the terms, review the literature, review how multidisciplinary treatment works for phagophobia, future research, a case example, and any questions you might have. So choking phobia is otherwise known as phagophobia. A lot of people just refer to it choking phobia because it's kind of clear by the name then what it is, but it's an anxiety disorder related to swallowing. So individuals are afraid or anxious to swallow food, liquid, and or pills. And this comes after having a traumatic or aversive oral experience. So these individuals then significantly restrict their oral intake, typically, sometimes to nothing at all. They won't take anything by mouth. Sometimes they won't even swallow their own spit. And then there's a range of restriction to their diet. For consequences, the individuals will typically lose weight. Some have dehydration, malnutrition, and or they're dependent on a supplemental feeding, and that can either be through a nasogastric or NG tube, or it can be that they're drinking supplemental beverages such as Pediasure, Ensure, Boost, things like that to help them keep up their nutrition, their energy, and their calories. Phagophobia is relatively rare and there's no known prevalence, but it is a typical onset and it is an acute condition, which is good. It doesn't take a long time to treat this condition, but it can be pretty severe when it does happen. It can occur at any age. It is more common in females, and there's high comorbidity with other anxiety disorders. Generalized anxiety disorder the most, but otherwise maybe specific phobias or separation anxiety or other things like that. The literature is really limited for phagophobia to single case studies or small studies, and mostly with the adult population. There's very few research articles on children with phagophobia. There also is no standard of treatment for this population. So various interventions are used in the literature, anywhere from psychoeducation, hypnosis, behavior or exposure therapy, psychotropic medication, and or cognitive behavioral therapy. The research that shows what's most effective is cognitive behavioral therapy and psychotropic medications. But again, there's not enough literature to really say these are our go-to interventions for this population. So Dr. Silverman and Godet and myself conducted a chart review. We saw a lot of these children and adolescents in our feeding clinic at Children's Wisconsin. So we decided to look back, do a retrospective review of some charts for these kids and see how we cared for them in our multidisciplinary team. So intervention included physician, dietitian, and psychologist with all of the patients that have choking phobia. We reviewed charts for 8 children. Half of them were female, half male. 7 were white and 1 African American. The mean age was just over 9.5 years old. So 50% of these patients that we looked at had a choking episode that initiated their choking phobia. 37.5 had a viral illness. And then there was a combination of choking and illness for 12.5% of the participants. Only 37.5% of the participants consumed food prior to treatment. So that means they were 100% dependent on their nasogastric tube for their calories and their intake. And some also had nutritional beverages, but did not have any food. So they either were dependent on a tube or they had nutritional beverages, but no food prior to treatment for 37.5% of these participants. So the chart review looked at what we did for these participants in terms of assessment, workup, and intervention. So there was always a medical intervention and workup, and then the workup was as needed for participants. But a GI doc always saw these patients first as the first approach to evaluate and make sure everything was physically safe with their swallowing. So medical workup included EGD, esophagram, upper GI, lateral neck x-rays, and or video swallow studies. Not all participants got the same workup, but these were some of the workups that were included. 3 participants were started on a proton pump inhibitor before the behavioral intervention, and that's because of the medical workup found some inflammation or some gastritis. There was no EOE or anything, any disease, but there was some signs of reflux, GERD, and inflammation in the esophagus. An NG tube was placed to stabilize 4 out of the 8 participants prior to behavioral intervention so that they could be medically stable and nutritionally stable before going through the behavioral intervention. And then the behavioral intervention included outpatient exposure therapy, just like you would do with anyone else that had a phobia. You do exposure therapy by myself, psychologist, every 1 to 2 weeks. And then one participant also needed an additional intensive outpatient therapy because his anxiety was so high and he wasn't progressing with his eating. So this intensive outpatient is 5 days of meals. So 3 meals a day for 5 days in our outpatient clinic by psychologists. And that helped him to then complete treatment. 3 of the 8 participants had a selective serotonin reuptake inhibitor, or SSRI, started during treatment, usually within the first 3 to 5 weeks. So that would be like Prozac or Zoloft, because their anxiety was too high and the exposure therapy wasn't working because they couldn't engage enough because they were too anxious. The average length of treatment when reviewing these charts was 9.75 feeding sessions. So that's behavioral sessions with the psychologist in just under 2 months. And in those under 2 months, there was a statistically significant increase in weight, food variety, and expansion of food textures. And I'll show you that in a minute. And then for those that have a nasogastric tube in, their tube was removed on average 6 weeks into behavioral intervention. So here's a graph of the weight change. So this is in Z-score because we wanted to compare for both change in weight, but also change in height. So we use the Z-score. The baseline, so this first point, is prior to them seeing me. And when they first came into either their pediatrician or the GI doctor's office to say, hey, we have this choking phobia that initiated. So that was the weight at that point. And then you can see there's a really big drop from the baseline to the pre-treatment. So pre-treatment is the first evaluation that I had with these patients, and their weight significantly decreased from baseline to pre-treatment. And then we do have a nice increase from pre-treatment to post-treatment, which was statistically significant change. And they did not, on average, gain all the way up to their baseline weight. But some of these patients were overweight, or they didn't need to get back up to that weight as long as they were in a good percentile and a good Z-score, which all of them were. They were all above 0 for Z-score. And this shows a number of foods participants consumed on average pre to post for each food group. So the first bar in each food group is the diagonal striped is pre-treatment, and the dark full solid bar is post-treatment. So we looked at grains, proteins, dairy, fruit, vegetables, and snacks. And you can see that there's a significant increase from both for pre-treatment to post-treatment for all food groups. And lastly, this is the average number of foods consumed in each food texture, again, pre to post. So the striped bar is on the left is pre-treatment, and then the solid black bar is post-treatment. And there was a just statistically significant difference for smooth, mashed, easily dissolvable, and solid foods. Lumpy did not have a significant difference, only because there were only 2 foods consumed, 0 at start and 2 post-treatment. That's not a texture that these kids are typically eating, because they're not in like stage 3 baby foods. They're eating typical child or adolescent foods, and there's not a lot of lumpy foods out there. So for the foods that these individuals would typically consume in their diet, there was a statistically significant difference for all textures. And that's really important because choking phobia has a very texture specific component to it. So smooth food is going to be much easier than an easily dissolvable, and that's going to be much easier than a solid food. So it is important to show that all of these patients really significantly increase, especially their solid food intake, which is the hardest food because that's the food that they're going to choke on if they're going to choke. So there are limitations of the study, of course, like every study. It was a retrospective review, so there's no cause and effect here. We did not claim that this intervention magically caused this, but it's just a review to say, hey, pre-post, this is what happened when we see these kids. So maybe we're onto something, and we need to then do another study to see if we can get cause and effect. We did have a small sample size and limited generalizability based on these limitations. So future research, we have just completed a prospective study using the Phagophobia shaping protocol that I developed. It's a larger sample size, 21 participants. So we are going to evaluate that data and publish that and present at that when that's completed. And then I also would like to do future research with multi-site study. So looking at different hospitals or different clinics, if this can be replicated. So I'm just going to review the phagophobia shaping intervention that I did. We did review. I don't have the full results yet, but just looking at what we kind of accomplished and the potential we have for that. So again, this was a prospective study. It was an intervention study with a larger sample size, 21 participants completed, and the participants were 4 to 18 years old. We use a multidisciplinary approach similar to the chart review with a medical and nutritional assessment, workup as needed, and then a referral to the pediatric psychologist, myself, when things were stable medically and nutritionally. And then if needed, medications were started. So for the behavioral component or the intervention component from psychology, we used a cognitive behavioral therapy approach, but more specifically, we developed a phagophobia shaping protocol where it's food exposure. So if you have a anxiety disorder, you do food challenge, or I'm sorry, you do exposure challenges with whatever you're afraid of. So this is similar. We then replicated that or adjusted that for the phagophobia population. So we use coping strategies while individuals were trying these foods. If they were anxious, like deep breathing, progressive muscle relaxation, distraction, and grounding. And we used a lot of thought challenging for the kids that were old enough to engage in thought challenging, calling it your scaredy brain that's trying to trick you and make you afraid that you think you can't eat and afraid of choking. The likelihood of choking again, because typically these individuals only had one choking episode in their entire life. And then altering the bite size to decrease the anxiety. So this is a shaping exposure protocol. So there's 9 levels, level 1 to level 9. Level 1 was just kissing the food. Level 2 was licking. 3 was taking rice-sized bites and then working that bite size all the way up to level 9. So this is the sheet I used to track where they were at what level they started at. Participants chose where they start and where they end for each session. But the goal was to work up to mastering that food and getting that level 9 or full spoon or bite swallowed. So now I'm going to go through a choking phobia case study quick. So this is a 6-year-old female. She had gradual decrease in intake of food after choking on a tortilla and became really dependent on Carnation breakfast essentials because she only accepted a few foods. So she really had a liquid diet. The GI physician evaluated her first and ruled out any organic causes. The speech and language pathologist also evaluated her and did a video swallow study showing that the swallow was normal, everything was intact. So the speech and language pathologist recommended behavioral therapy with psychology. So the interventions we used were mealtime schedule structure with meals and snacks every 3 hours, always eat food with the Carnation, so she's not just drinking the calories. We use the gradual shaping approach I just explained. And we worked up from smooth foods all the way up to regular solid foods. And then the patient completed treatment in 8 sessions. She is now eating 25 foods compared to 5 foods at the start of treatment, and she denies any anxiety or concern about choking. Family was very happy that she had made so much progress, and they felt that she could continue to eat whatever food was offered to her at home, at restaurants, at social events without any anxiety or fear any longer. So that's it. If you have any questions, here's my contact information, my email at Children's and my phone number at Children's as well. And I look forward to hopefully presenting my next research study at your conference again next year. Thank you so much for being here, and please reach out if you have any questions, concerns, or would like to collaborate at all.